Hi everyone. One of the important view is IVC, and most of the time with aorta at least proximal too. Because IVC size and collapsibility is very important for calculating pulmonary pressure, and even in that level, we have middle hepatic vein
Even in
for
that,
evaluating a severity of the moderate to severe tricuspid regurgitation, or the status of the central venous system. Is if the patient is hypovolumic or not, can we still administrate more fluid or not? So knowing the size and collapsibility of IVC is very important and helpful in management of the patient. So, and generally, the regular classic approach for IVC and proximal aorta is subcostal. You go below the xiphoid process, and we put, imagine this is probe, footprint, marker. You hold it at 12 o'clock below the subxiphoid, and firmly press, and as the patient breathe in, and meanwhile we fan left and right, we will see one of them, then based on the feature of that one angle the other side, we find the other one. Is most of the time this technique subcostal or subxiphoid is working very well, but as we know in many patients, especially in hospital patient, inpatient like the ICU, CCU, they are very challenging. They are on the ventilator, gassy, or they have gastrostomy or surgery, scar tissue. In those cases, we don't have subcostal window. What option we have? For those cases, we can go approach hepatic window. For hepatic window, as the name comes, we use a lever as a acoustic window. What we do at the same level of the subxiphoid, a little upper or lower, we slide to the right side of the patient, somewhere around the mid clavicle. Here is clavicle, mid clavicle, and pointing toward the IVC and aorta. As we know, the direction and location of IVC and aorta at the mid deep posterior to the abdomen. So we're pointing that imaginary location of the IVC and aorta. Just when we do it, fan it left and right, suddenly one of them, or most of the time, both of them show up. First, we will see a skin lever as an acoustic window, and below the bottom of our image, we will see first IVC, because IVC in the right side. Then posterior to the IVC, we will see aorta. In this case, almost over 90% of the cases, we can get it IVC and aorta very easy, and do respiratory variation or collapsibility, and even middle, not middle, one of the branches of the hepatic vein, we can catch it and do Doppler if we need, and Doppler for aorta, so on. So this hepatic window is very helpful, and I recommend to all of you, whenever you don't see IVC clear, or you don't have subcostal window, go hepatic window and fan it. And almost, except those cases that the patient has fatty liver grade 2 or 3, or they have some pathology on the liver, that the penetration of the sound decrease. Except those cases, in other cases, with optimizing, decreasing frequency, increasing penetration, almost always we can get IVC and aorta. I hope it was useful. Up to the next time. Have a wonderful time.